When it comes to diagnosing disorders of the temporomandibular joint, imaging is our window into understanding what's really going on, from the familiar OPG to advanced modalities like CT and MRI. Each technique offers unique insights, and knowing when and how to use them can make all the difference in diagnosis and treatment. This evening, we'll explore the TMJ in detail, looking at anatomy, scope, and limitations of each imaging method, and most importantly, how to interpret what we see in real clinical cases. Welcome to this Tuesday's live stream of the Dentistry Special Series on Oral Pathology 360, where we look at diseases and their management with a holistic 360-degree view. I'm Dr. Mandana Donahue, your host for the live stream and founder director of Oral Pathology 360. For those of you who are joining us for the first time, welcome. While you can watch the session from anywhere, wherever you find the video playing, that could be on our website, on any of our social media pages. But to comment and ask questions, you need to be logged into your YouTube account. So head to YouTube if you would like to interact. We have a live Q&A after the lecture, and we will be putting your questions and comments to our speaker. In the meanwhile, you can put your questions along as we go on. You don't have to wait till the end. And coming on to some information, our channel membership is open and it comes with some great perks, including certificates for attending live streams, access to exclusive content, and more. To join, all you need to do is click the join button, which is seen below the video, and choose the category that you like. Now, your support in this way enables us to continue creating high quality educational content that remains freely accessible to all. And yes, if you are a member and attending this session live, you are eligible for a certificate of participation. How you can get it is just let us know you are here by interacting with us in the live chat and then fill out the form. The link for the form is shared in the posts, in the channel posts, and you have to fill it up within 24 hours. Going on, let's welcome our two latest members, Dr. Yashika Kevalraman and Dr. Virendra Kumar Jaisal. They have joined us in the last week, and we are so glad to have them with us. Now, going on with the next part and the event. It is my pleasure to welcome Dr. Easwaran Ramaswami, Professor and Head of Department of Oral Medicine and Radiology at Government Dental College and Hospital, Mumbai. With over 2 decades of experience, multiple awards for excellence in oral surgery and oral medicine, patents, publications, and textbook contributions, Dr. Iswaran brings both academic depth and practical insights to the field of advanced radiographic interpretation. So let me just bring him in and we can all say hello. Welcome, Dr. Iswaran. It is wonderful to have you with us.
Hello, good evening, all of you.
So I think we will go on as usual. We will watch the lecture and then come back for further discussions, and you can then interact more with Dr. Ishwaran.
Greetings to all delegates. Today I'll be talking upon the topic temporomandibular joint imaging, conventional to advanced. This presentation comes to you from the Government Medical College and Hospital, Mumbai. As we all know, temporomandibular joint is a very complex joint, both anatomically as well as physiologically. Diagnosing temporomandibular joint disorders requires a thorough clinical evaluation and radiographic evaluation as well. When it comes to radiographic evaluation of temporomandibular joint, we have several different methods which can be utilized. I have broadly classified them into the conventional methods and the advanced methods. The conventional methods include the age-old methods like transpharyngeal view, transorbital, transcranial, reverse Townes view. What is more familiar for us these days is the orthopantomogram, the TMJ open and closed mouth views. Sometimes when the disease is far severe, these conventional imaging modalities may not be sufficient. In such cases, we may have to go ahead with certain advanced imaging methods, which includes computed tomography, cone beam computed tomography, magnetic resonance imaging, and nuclear medicine. In today's presentation, I'll be covering about the indications of different radiographic techniques, that is both conventional as well as advantages, how to appreciate the normal anatomical landmarks on these, and how to identify the various pathologies. This we'll study using different cases as examples. So to begin with the conventional radiographic methods, which includes transpharyngeal, transorbital, and transcranial. Now you might be wondering, why am I talking about these conventional radiographic views? Because in many places these have become obsolete. With the advent of orthopantomogram and the CT and MRI, we rarely use these transpharyngeal, transorbital views. However, I would like to remind you that in situations where the advanced imaging methods may not be available for the clinicians, these age-old methods of conventional imaging plays a very important role to identify temporomandibular joint disorders. In many scenarios, it can be a simple screening radiograph to identify the disease, which can be, if required, confirmed later using advanced imaging. So, to begin with, we shall start with the transpharyngeal view. The transpharyngeal view is a lateral view of temporomandibular joint, where the cassette is placed over the temporomandibular joint of the affected side, and the central ray passes from the opposite side. Now, because the rays pass through the pharyngeal area of the patient, it is called as transpharyngeal view. And as you can see here, this view shows an excellent demonstration of the head of the condyle. The head of condyle is over here, the sigmoid notches here, and the subcondylar areas are seen over here. The transpharyngeal view is indicated to study for condylar changes in case of arthritis, study for subcondylar fractures. So that's a normal transpharyngeal view. The articular eminence is over here, glenoid fossa, and the head of condyle, that is a part of temporomandibular joint. Here in this radiograph, you can see that there is flattening of the head of the condyle, and there is a formation of a beaking, that is an indicative of early arthritic changes. So such arthritic changes can be easily identified using the transpharyngeal view. Apart from this temporomandibular joint, the transpharyngeal view also can be used to demonstrate styloid process. For example, if you see here, that is the styloid process. In case of elongated styloid ligament or elongated styloid process, this radiograph can be of a valuable tool for diagnosing these conditions. The second conventional radiographic view is the transorbital view. Now, unlike the previous transpharyngeal view, the transorbital view is a antero-posterior view, which means the cassette is going to be placed behind the patient, sensor is behind the patient, and the rays are directed from the front through the medial campus of the orbit. So, obviously, this is going to demonstrate the mediolateral aspect of the condyle. So, as you can see here, this is the lateral pole of the condyle, superior surface of the condyle, and the medial pole of the condyle. And you can see the neck of the condyle over here. This radiopaque structure demonstrates the zygomatic arch, and this vertical radiopaque structure is the styloid process. So here we have the mastoid process. Transorbital view has to be taken with the patient's mouth kept open. Otherwise, the mastoid process may completely superimpose over the head of condyle, and it might obscure the condyle completely. The primary indications for transorbital view indicates any arthritic changes in the head of the condyle, to study for fractures involving the condyle, specifically mediolateral displacement of the condylar fractures, subcondylar fractures. Transorbital view can be very useful. Here I have an example of a transorbital view where you can appreciate there is a low subcondylar fracture that can be seen over here. The head of condyle is here, the lateral pole and the medial pole, and you can see a fracture line. However, this fractured condyle has not got displaced. It is in the straight line. But in this case, it is slightly different. The head of condyle has got displaced slightly medial. Can you appreciate that? The medial pole, lateral pole, superior surface, and the fracture is over here. And the fractured portion of the condyle has got displaced medially. So, such simple radiographs can be used to demonstrate or diagnose temporomandibular joint disorders, including fractures and arthritis. Now we come on to the third one, that is a transcranial view, supposed to be the most difficult radiographic technique wise. So this radiograph can be taken in both closed mouth as well as open mouth. So let us first see the closed mouth radiograph. The head of condyle is present over here. This is the articular eminence over here, and this is the glenoid fossa, and the condyle is present well inside the glenoid fossa, which means that the mouth is in the closed position. Behind that, we have the external artery meatus. Now, apart from that, we can also take the transcranial view in the open mouth position, wherein we can see that the mouth is kept open, and because of that, what has happened is the condyle has moved slightly forward. The fossa is empty over here, and the condyle has moved forward. So the primary indication for this radiograph is to study for the joint space. As you can see in the closed mouth, the joint space is seen very clearly. In conditions like arthritis, when the joint space gets reduced, or patients with temporomandibular joint ankylosis also, you can take this transcranial view to demonstrate the joint space. Additionally, because we can take it in both open mouth and closed mouth position, this radiograph can be also done to study the extent of movement of the condyle. Now, in this case, the head of condyle is moved slightly anterior to the articular eminence. Okay? So, in case the patient is having some internal disc derangement or ankylosis, the movement of condyle will not be so much, it will be slightly restricted. That is a transcranial view. Then we have the reverse Towns view. Reverse Towns view is a posterior anterior view where the sensor is placed in front of the patient and the rays come from behind. This technique is also taken with the patient's mouth kept open and it can demonstrate subcondylar fractures. Here we have the head of the condyle seen, the lateral pore of the condyle and the medial pore, and we can see the neck of the condyle. The primary indication for a reverse Towns view is study the subcondylar fracture. As you can see in this case, now compared to the left side where the condyle looks normal, the neck of the condyle looks normal. That is the ramus, angle of mandible and the lower border of mandible. On the right side, we can appreciate that there is a low subcondylar fracture and the fractured segment has slightly got displaced on the lateral aspect. So it's also a very nice view wherein we can demonstrate the subcondylar fracture, and that is a primary indication of reverse Towns view. The next view is the orthopantomogram. Of course, everybody is familiar with the OPG, and I think after the advent of OPG, the previous conventional views which I have covered are no more in use. However, because of its historical importance and clinical significance, I have tried to cover them in the present talk. So these days, the preliminary radiograph of choice or the screening radiograph for most temporomandibular joint disorders is the orthopantomogram. Yes, OPG shows the condyles very clearly. So if you can see the normal condyle, head of condyle is supposed to be smooth and round. The cortication has to be maintained. Here we can see the articular eminence and the glenoid fossa. This dark area in between is the joint space. The subcondylar area, the neck of the condyle, posterior border of ramus, angle of mandible, and the lower border of mandible. And we come on to the opposite side, angle of mandible, posterior border of mandible, and here again we have the head of condyle, the sigmoid notch, coronoid process, and then the anterior border of ramus. So if we try to interpret the OPG in this sequence, particularly for the temporomandibular joint, you are not likely to miss out on any minor changes that the OPG might be showing. So OPG is a very important tool for diagnosing temporomandibular joint disorders. The indications for OPG in TMJ disorders is, well, we can study TMJ ankylosis, we can study arthritis of temporomandibular joint, we can see for any developmental anomalies like condylar hyperplasia, condylar hypoplasia, fractures involving the condyle, subcondylar fractures. So OPG has got a wide variety of applications for temporomandibular joint disorders. Now here I am showing an OPG. So I'll ask a question to you. Is this OPG normal? So let us try to trace the condyle. Now this time we'll start on the left side. The condylar head is seen over here. The complete condylar head is not seen. Part of it has got cut off in the image. The neck of the condyle, lower border of mandible opposite side. Now when we come on to the right side condyle, I am able to see two radiopaque structures. One is this outline of the condyle and second is this outline. What is the meaning of that? It means that there is a sagittal split fracture of the condyle. That means that there's a high level intracapsular fracture involving the temporomandibular joint, and the fracture has split the head of condyle sagittally into two pieces. The displaced fragment could be either placed medially or laterally, which can't be confirmed over the using the OPG. We will require either reverse Towns view or we may require the CT or CBCT for confirmation. But this type of a double condyle sign is indicative of a possibility of a transverse fracture of the sagittal split fracture of the condyle. Now I would like to gain your attention to any other finding. Can you observe here? Here we can appreciate there is a bilaterally elongated styloid ligament. So can you see this? The styloid process, the entire styloid ligament has got calcified on both the sides, the left side here and the right side here. Almost up to the hyoid bone, we can see that the styloid ligament has got calcified. So that's an additional incidental finding which we noted in this case where there was elongated styloid process. Now, there is a fault in this radiograph. I have deliberately shown this radiograph because whenever we take the radiograph for temporomandibular joint, the OPG particularly, the patient positioning is very important. Here, what has happened is that the patient is looking slightly downwards, because of which the smile line of the OPG, or what we call as the smiling OPG, has come. And because of this problem, what has happened is part of the condyle has got cut off. So when the patient is not positioned properly for the panoramic radiology, this is possible. When the patient looks down too much, the condyles will move towards the upper border of the film, and part of the condyles will get cut off, as you can see over here. So that should be avoided whenever you check for any kind of temporomandibular joint disorders. Next, we go on to the TMJ open and closed mouth view. Now, most of the OPG machines, the panoramic radiographic machine, provide this facility of open and closed mouth temporomandibular joint views, where the machine rotates twice. In the first rotation, the patient's mouth is kept closed, and the right side and the left side condyles are scanned. In the second, before the second rotation, the patient's mouth is kept open, and the right side and left side open mouth positions are recorded. So this is the open and closed mouth TMJ view, which we have taken using the panoramic radiography machine. So what is seen here in the closed mouth, you can appreciate the head of condyle is clear, the glenoid fossa and the articular eminence. In the open mouth position, the condyle has moved ahead. So how do we know that? The glenoid fossa is empty over here. The articular eminence is seen over here. In a normal complete open mouth position, the head of condyle has to come to lie just below the summit of the articular eminence. That means on the right side, the movement is completely normal. Let's see about the left side. Here also, we appreciate the condylar outlines are very smooth, clear, the cortication is maintained, no arthritic changes, and this is the glenoid fossa and the articular eminence. In the open mouth, the condyle has moved forward, the fossa is empty over here. The condyle has moved forward, and the condyle lies just below the summit of the articular eminence. So that's the normal open and closed mouth radiograph of the temporomandibular joint. So with that in mind, we go on to one particular case where we have the open and closed mouth. Right side closed, right side open, left side closed, and left side open. So what is the pathology over here? So if you see in the closed mouth, the condyle is normally placed, the cortical outlines are maintained, joint space is clear, articular eminence is clear. However, when the patient opens the mouth, the condyle lies cross the articular eminence. So in a normal condyle, the head of condyle should lie at this position where I am pointing out the arrow, because that is a normal mouth opening position. So here the right side condyle has moved ahead of the articular eminence. This is a condition called as subluxation, or there is a hypermobility of the temporomandibular joint. Now similar thing has happened on the left side also. So here in the closed mouth, you can see that the condyle is normal, cortication is maintained, joint space normal. When the patient opened the mouth, the eminence is over here. Instead of the condyle being in this place, it has moved far anterior. This means that there is hypermobility of the temporomandibular joint, also what we call as subluxation of the temporomandibular joint. So this type of open and closed mouth TMJ views are extremely useful for studying cases like subluxation, or even cases like internal disc derangement, where though the disc is not seen on the panoramic radiograph, depending upon the amount of movement of the condyle, we can suspect that there could be a disc anomaly. So we come on to the next case. Here, if you see the left side, the condyle in the closed mouth position and open mouth. So if you see, there is not much of a change. In spite of the mouth kept open, the condyle has not moved much forwards. It is still within the glenoid fossa. It should have come at this point, but it has not moved. That means the movement on the right side is slightly restricted. However, on the left side, if you see, in the closed mouth, the condyle is normal, and in the open mouth, also the condyle has moved forwards. It has come just below the articular eminence. This means that on the right side, the movement of condyle is slightly reduced. So this can happen in cases of unilateral internal disc derangement without reduction. So here what happens is the disc is anteriorly repositioned, and when the patient tries to open the mouth, the disc does not go back to its place, and therefore it prevents the mouth opening from coming to a complete state. So though, as I said earlier, OPGs do not show the disc directly, This was one case of IDD, internal anterior disc derangement without reduction, where the condylar movements were inadequate on one side. This can lead to deflection of the jaw also towards the affected side. So these open and closed mouth TMJ views are also very important conventional radiographic techniques which can be used in the diagnosis of temporomandibular joint disorders. Now coming on to little more advanced techniques in which we have computed tomography, MRI, CBCT and others. So computed tomography is one beautiful imaging technique which has revolutionized the field of maxillofacial radiology, especially with the advent of CBCT, which provides comparable images of the temporomandibular joint as the CT scan with a very much reduced radiation exposure. CBCT is the radiographic imaging of choice whenever you want to check for any osseous changes involving the temporomandibular joint. Now, because we are dealing with the hard tissue structures, I will be using CBCT and the bone window of CT synonymously over here because we are not seeing any soft tissue structures over here. So as you all know, in computed tomography, we can see three different slices. The axial sections, which are taken along the axial plane, coronal sections, which are taken parallel to the coronal suture of the head, and the sagittal section, which are taken from right to left or the left to right. So here in the axial section, that is how the condyles will be. The condyles will be seen at the level of the zygomatic arch. So can you see here? This is zygomatic arch over here. The upper portion of the maxillary sinus, pterygoid plates can be seen, nasal cavity can be seen, and the occipital condyle of the skull can be seen. So in the same level, we can appreciate the head of the condyle. The medial pole is seen, lateral pole is seen, the joint space is here, and this is the outline of the glenoid fossa of the right side. Similarly, you can also see on the left side. This hyperdense structure that you see in front of the condyle is the coronoid process of the mandible. So that is how the TMJs can be visualized on the axial section of the computed tomography or even the cone beam computed tomography. When it comes to the coronal section, it will look something like an anterior-posterior view where you can see the neck of the condyle, the medial pole, superior surface, lateral surface. The joint space has to be seen clearly. As you can see here, joint space is clear. Towards the lateral part, slightly joint spaces, slightly reduced. Okay? The upper component, that is the margin of the glenoid fossa, also appears to be clear. So a normal, healthy temporomandibular joint will show a normal rounded condyle with the intact cortication, no appearance of any erosions or spurs, and a uniform joint space. That's how a normal condyle can be visualized. The same thing can be seen on the sagittal section also. So we are seeing it from the lateral aspect. So here we have the head of the condyle, neck of the condyle. This is the margin of your glenoid fossa. Here we have the articular eminence that is present over here. Behind the head of condyle, we have the external auditory meatus and the mastoid airspace behind that. So that is how the normal condyle. Again, you can appreciate there is a uniform joint space, which means that there is no adhesions or there are no ankylosis involved in the temporomandibular joint. So that's how normal temporomandibular joints can be seen in the different sections of CT or CBCT. Now let us study some pathologies. So here I have a panoramic radiograph where you can see there is a right side condyle and left side condyle. Now, as I told you earlier in the previous case, when you take a very casual cursory glance, it appears that the condyle here is normal, but it does not have the usual density. Similarly, on the right side also, the condyle can be seen, but here you can see one more small radiopaque structure on the right side. Similar thing can be seen on the left side also, which is again indicative of a sagittal split fracture of the condyle. That is a transverse fracture involving the head of the condyle can be seen over here. So which is indicative that there is a split fracture. So such radiographs do not demonstrate the medial or lateral displacement of the condyle. We require advanced imaging methods like a CT scan or a CBCT scan. So I will show you the CT images. So this is the right side temporomandibular joint. The condyle is fractured and the condyle is also moved slightly outside the fossa. That is the normal outline of the glenoid fossa over here. And we can appreciate that the condyle has moved slightly outside the glenoid fossa. And this hyperdense structure that you see over here, that is the displaced fragment of the medial pole of the condyle. Similarly, on the left side also, we can appreciate that the condyle is fractured and the fractured segment is moved medially down over here. And the condyle itself has got displaced superiorly and lateral to the normal position outside the glenoid fossa. So certain information which we cannot get using the conventional radiographic imaging can be obtained using the CT or the CBCT, and that is a major advantage and indication for these advanced methods like CT scan, which can be indicated for studying the fractures involving the condyle, arthritic changes, developmental anomalies, and many more complicated conditions of the condyle. Next, this is a very interesting case that I would like to share with all of you. So first of all, we'll see the panoramic radiograph. So the right side condyle appears to be normal. Glenoid fossa is normal. Coronoid process is normal. Now, why am I trying to compare with the right side? It's a golden rule of interpretation that always try to compare both sides. Anatomy and anatomical variations are usually bilaterally symmetrical, with exceptions, of course. But when you have some difference in the symmetry, it could indicate that there is a pathology. So as you can see in this case, the left side condyle is not as clearly seen as the right side condyle. It appears as if the neck of the condyle is very short and the condylar head is placed much below. This patient had a long history of trauma during childhood, and subsequently no treatment was done, and the patient did not know that he had a fracture of the condyle or not. He reported with the difficulty in opening the mouth. So when we took the OPG, we found that the left side condyle was not normal. So we'll see the next radiograph. We have taken a transorbital view. Now, why a transorbital view was taken is because I wanted to see the mediolateral positioning of condyle. So here we can see that the head of condyle appears to be of a different shape. There is no evidence of fracture because it was a very old history of trauma. And even if there would have been a fracture, by this time it would have got malunited. So this is what the picture seen in the transorbital, which looked something like a bifid condyle. To confirm the findings, we have taken a CBCT image also, which shows that the condyle appears to be slightly bifid. Now I have a question to all of you. Is this really a bifid condyle, or are we seeing at some other pathology? The answer is very simple. If it is a bifid condyle, the entire condyle, the bifid condyle appears very similar to this, where there is the what you call a forked appearance of the condyle because of the two depression in the center over here. In case of a bifid condyle, the entire condyle would have been inside the glenoid fossa. That is the glenoid fossa over here. However, in this case, it was not the scenario. This part of the condyle which was seen was placed outside the glenoid fossa, which means that this was not a bifid condyle. So what was this? This was a case of an old malunited fracture. The patient must have had a split fracture early in childhood, which was not treated. And over a period of time, this has got malunited. And that is how now it looks like a bifid condyle on the CT scan or even the transorbital view. Now, I would like to show one example of bifid condyle as well as the fracture. This is the case which you saw previously. And this is an example of a bilateral bifid condyle. So if you can see here, the condyle is within the confines of the glenoid fossa. It has not moved outside the glenoid fossa, whereas in this case, this fractured condyle, which is malunited, has come outside the confines of the glenoid fossa. So as a radiologist, we need to pay attention to many small, minute details which can help in the differential diagnosis. This is another case where the patient reported with pain and difficulty in opening the mouth and pain over the left temporomandibular joint. So let us follow our traditional method. This is where you find that there is the right side condyle is intact, but in the left side condyle, the joint space appears to be slightly unclear, and there is some abnormal radiopaque mass that can be seen over here. So because the picture is not very clear, we have taken some CBCT sections. The right side condyle appears to be completely normal. The joint space is seen uniform. The cortical outlines are maintained. However, on the left side, if you see over here, there is a reduced joint space. There is a nearly bone-to-bone contact that can be seen. Moreover, just below the cortical plate, we can see there is subchondral sclerosis. This hyperdense band that you see below the cortical bone is called as subchondral sclerosis. Can you see a small hypodense cyst-like area? That is called as a Ellis cyst. Now, Ellis cyst is not a true cyst, but a kind of a cyst-like appearance that can be seen in patients with osteoarthritis of the temporomandibular joints. Apart from that, here if you see in this related section, you can appreciate a small hyperdense structure that is seen within the joint space. That is, the head of condyle is seen over here, and the glenoid fossa is seen. And inside the joint space, we could see a small hyperdense mass that is called as a joint mouse. So, what is a joint mouse? Joint mouse are nothing but they are the displaced osteophytes which can be seen in patients with osteoarthritis. So, what findings could not be seen clearly in the OPG are now demonstrated beautifully using the CBCT images. Okay, so that is how CBCT is very valuable in the diagnosis of temporomandibular joint disorders. So here we have another case where on the right side again the condyle looks normal, but on the left side the entire condylar anatomy appears to be slightly mutilated. You can see a large radiopaque mass that is replacing the head of condyle. The joint space appears to be irregular and reduced. The ramus appears to be very short. Antegonal notch appears to be prominent and teeth are placed inside the ramus. That's a classical radiographic appearance that you see in case of temporomandibular joint ankylosis. So here we have ankylosis only of one side, left side unilateral temporomandibular joint ankylosis can be seen. The same thing can be seen on the CT image also. So here if you see joint space is irregular and the head of condyle shows wavy appearance and there is the abnormal radiopaque mass, hyperdense mass is seen. The condylar shape appears to be large and that's an example of a fibrous ankylosis involving the left side temporomandibular joint. Now, whenever we do imaging studies of ankylosing patients, it's a very good practice to include airway analysis. Now, what happens in temporomandibular joint ankylosis is that because the condyle is the growth center of the mandible, in patients who have got childhood trauma and subsequently when they develop TMJ ankylosis, the mandible is severely retrognathic and this can compromise the airway space. So as you can see here, we have used the CBCT software and we have found that the volume of the airway is much restricted. This happens because of the backward placement of mandible, because of which the tongue is also positioned posteriorly and effectively it can compromise the patient's airway. So that is how whenever we do imaging studies for TM joint ankylosis, not only the joint parameters, even the airway spaces have to be analyzed clearly. This is an example of a bird face deformity. We all must have heard this term. Bird face deformity seen in case of TMG ankylosis. Now, because of the severe mandibular retrognathism, the face has got a convex profile, and that's how patients with bilateral TMG ankylosis may present with. Now, ankylosis can be of two types, bony ankylosis and fibrous ankylosis. Now, in this case, what I'm showing you is there is complete bone-to-bone fusion. The head of condyle and the fossa cannot be separated. Joint space is not seen. That is why we can call it as a bony ankylosis. In this case, we can see there's an irregular joint space over here. There is no complete bone-to-bone fusion. However, the condylar head is quite abnormal. And this is called as a jigsaw puzzle pattern where the lower compartment of the head of condyle fits into the upper portion of the glenoid fossa like a jigsaw puzzle. So one example of bony ankylosis and one example of a fibrous ankylosis. The radiographs are not of the same patient. I have just shown different pictures to explain how bird face deformity, bony ankylosis, and fibrous ankylosis can be seen on the radiographs. Coming on to some developmental anomalies, this case is quite obvious. The entire right side is large. There is a huge right side condyle. The ramus of mandible is elongated and you can see a step deformity in the mandible that is called as a right condylar hyperplasia. And CBCT, especially with its different features of giving you 3D images and superimposition of soft tissue profile as well as airways can be used to study cases of condylar hypertrophy or condylar hyperplasia. So as you can see here, there's a gross asymmetry of the face because of the right side condylar hyperplasia and the condyle appears to be slightly J-shaped. And we can also use the CBCT cross sections for diagnosing these cases. Now, this is a quiz for all the listeners over here. Can you identify what is the pathology over here? We are looking at the axial section of the CT scan passing through the level of the condyles. So this is the normal glenoid fossa. Zygomatic arch seen over here on both the sides. However, the condyles are not seen inside the fossa. So where are the condyles gone? The condyles have moved anteriorly. The condyles have come over here. So what does it mean? This is a case of dislocation of the condyle, bilateral condylar dislocation. I will show you another image which is quite clear over here. So same patients, sagittal section, the fossa is empty, the eminence is over here, and the condyle is completely moved outside the eminence, and the patient is now not able to close the mouth because the condyles have got blocked on the posterior surface by the articular eminence. So it's a case of condylar dislocation where we can appreciate the faulty positioning of the head of the condyle. This is a condition called as synovial synchondrosis, where within the joint capsule, apart from the condyle, you will find multiple radiopaque masses or multiple hyperdense masses. Synovial chondromatosis can present with clinical symptoms of pain, difficulty in opening the mouth, or sometimes in mild cases, it can also be a coincidental finding. It's a very rare finding, but CT scans and CBCTs are extremely useful for identifying this condition called as synovial chondromatosis. Here we have a classical example of bilateral condylar fractures where the head of condyles have got tilted medially. So that is how CT scan and CBCT play a vital role in diagnosing temporomandibular joint disorders. Now here we have a case where the entire left side mandible, that is the mandibular ramus and the condyle was not seen, and the morphology of the condyle ramus, nothing were appreciated. The patient presented with a draining sinus tract and a painful tender erythematous swelling over the angle of mandible. We suspected it could be some osteolytic lesion, maybe osteomyelitis involving the left side ramus. And when the CT scan was taken, as you can see here, again, the right side is normal. Left side, the condylar head is not seen clearly, and exuberant periosteal reaction can be seen. That is the outline of the ramus. And around the ramus, we can appreciate there is an exuberant periosteal reaction. We can appreciate that even in the axial section. This was a case of tuberculous osteomyelitis involving the entire left side mandible as well as the condyle. So the temporomandibular joints may also be sometimes site for conditions like tuberculous osteomyelitis, metastatic tumors, or even any other kind of neoplasms can also involve the temporomandibular joint. So CT scan is very useful for diagnosing these conditions. Now coming on to the next imaging method, that is the MRI scan. Now so far whatever imaging modalities we saw, they could demonstrate the bony architecture of the condyles very clearly, but the disc was not seen clearly. MRI of the temporomandibular joint is primarily indicated to study for disc anomalies. So traditionally we use the T1 weighted sequences, where in the normal closed mouth technique, this iso-intense structure that you see over here at the 11 o'clock position, that is the intra-articular disc of the temporomandibular joint. Here we have the head of the condyle, the articular eminence, glenoid fossa, and the external auditory meatus. And this is this hypointense, that is the dark outline is the cortical outline of the head of the condyle. And that's how the normal disc appears in the closed mouth position. When the patient opens the mouth, when we take an open mouth MRI, we can see that the disc has got stretched behind and it has got a classical bow tie. Bow tie means a bow that is kept over the tie. That is the bow tie appearance of the disc can be appreciated. So that's how you can see the normal open mouth over here and closed mouth disc. Let us try to study how the abnormal disc positions can be seen on MRI. Here we can see a case of anterior disc displacement without reduction. So how do we diagnose that? In the closed mouth, the disc is placed anteriorly. Can you appreciate this? The disc should have been slightly more superiorly placed, but it has come down to the 9 o'clock position. But when the patient tries to open the mouth, in the open mouth MRI, the disc is going back to its normal position. That is called as the anterior disc displacement with reduction. So when the patient opens the mouth, as the disc goes back, the patient will have a clicking sound, and that is followed by a normal open mouth positioning of the intra-articular disc. So now what happens in case of anterior displacement without reduction? So if you see here, in the closed mouth, the disc is anteriorly placed. When the patient tries to open the mouth, the disc is getting folded over here. Instead of the disc going back to its place, the disc is getting folded. And as you can see here, the condyle could not move completely. The condyle should have come till here, but the condylar movements are restricted because of the curling or folding of the disc. That is called as anterior disc displacement without reduction. So this appearance is called as the gumball effect, where the disc completely curls up becomes like a ball, and it also impedes the movement of the condyle. So by taking open mouth and closed mouth position of the temporomandibular joint, we can study the internal disc displacement very beautifully using MRI scans. Here we can appreciate the normal appearance of the disc in the mediolateral plane. So when you want to study the mediolateral plane, we should check the coronal section. So here we have the medial pole and the lateral pole, and this iso-intense structure is the disc of the joint. Okay, it's a normal positioning. Here you can appreciate the disc has got displaced laterally. So it is not just anteriorly. Sometimes the disc also can get displaced little bit laterally. This iso-intense structure here is the lateral pterygoid muscle, which partly inserts into the disc. Here we have the medial pterygoid muscle, and here we have the masseter on the outer aspect of the mandible. So that is an example of lateral displacement of the disc. Likewise, here we have the medial displacement. So instead of the disc being in the center, it's appearing to be overflowing over the medial aspect. So these are all the different types of disc derangement which can be studied on MRI scans. Now, rarely we may come across posterior displacement of the disc. As you can see here, the disc has got displaced posteriorly. It's a very rare clinical situation. Mostly we find the disc displaces anterior. That is because the disc is attached to the anterior part of disc is attached to the lateral pterygoid muscle. So any spasm of this muscle can cause anterior disc displacement. Now, the T2 weighted sequence of MRI can be used to demonstrate for edema inside the gland, inside the joint. For example, in arthritis cases, fluid accumulation, the hyperintense signals that you see over here and here indicate that there is fluid inside the joint. That is a commonly found appearance in case of arthritis where there is edema of the temporomandibular joint. So after having seen all these methods, we will come towards the end of the presentation where one last imaging method, that is the nuclear medicine image. I will demonstrate two cases before I conclude the presentation. This is a very interesting case. A elderly female reported with pain over the left side condyle and paresthesia over the mandible for past few months. And when the OPG was taken, the left side condyle was not seen clearly. It appeared to be very hazy, and the neck of the condyle also appeared to be quite hazy. So we suspect it could be a case of osteomyelitis, something similar to what we saw in the previous slides. So, and therefore a CBCT scan was done, and CBCT scan also showed that there was a irregular destructive area involved in the entire condyle, which can be seen in the coronal, sagittal as well as the axial section. The right side is normal and the left side is abnormal. Okay. However, when a medical history was taken, the patient said that she had a past history of breast cancer for which she was treated. However, because there was a history of breast cancer, we also thought this could be a case of metastatic recurrent tumor of the condyle. And therefore, we went in for a functional imaging modality where we did a PET-CT scan. PET-CT scan is a condition where it's a situation where the PET scan of the patient is taken, that is a positron emission tomography scan is taken, and that is combined or overlapped over the CT scan. And we could see a hot spot over the left condyle, which confirmed that this was a metastatic deposit in the left side condyle. Now, additionally, the patient also said that she had pain in the hip joint. So when the PET-CT was seen, we could also see that there was a metastatic deposit over the left side hip joint as well. So that is how when you take a functional imaging methods like scintigraphy or a PET scan and superimpose that with CT scan, fusion images can give you very important clue about the distant metastasis or the functional activity involved in the temporomandibular joint. The last case for my presentation today, a young male presented with deviation and asymmetry of the face. And when we suspected it could be a case of left side condylar hyperplasia because the chin was deviating towards the right side. But when we see the condyle, the left side condyle is marginally bigger as compared to the right side. It is not very prominent like we saw in the previous case. It is marginally bigger. Now the question is there really a condylar hyperplasia? And because the patient was in his early 20s, is the growth persisting or has the growth completely stopped? So for that, we can go in for functional imaging methods like PET scan and PET-CT. And what we saw that the left side condyle showed areas of hyperactivity, which indicated that there was a persistent hyperactivity of the left side condyle, and the case was diagnosed as left side condylar hyperplasia with the persistent activity of the left side condyle. So that is how functional imaging modalities can be very useful for diagnosing temporomandibular joint disorders. And with the availability of fusion imaging, we can combine the PET scan with the CT scan and have a PET CT image, which can give a very clear idea about the ongoing functional as well as anatomical changes taking place in the condyle. So now that we have seen many conventional and advanced imaging modalities, I would like to conclude by saying that with the availability of so much imaging modalities, the clinician must choose the right imaging modality for the particular clinical situation. A golden rule would be always to begin with any of these conventional imaging methods as a screening methods because they involve less radiation exposure, they are easily available, and it is also cost effective. And when further confirmation is required, we may go in for a CT scan, a CBCT scan, an MRI scan, or sometimes even a functional imaging methods. However, the right indication of the right imaging modality should be very clear. Otherwise, we may not get adequate information from the imaging process. That's how radiology can play a very crucial role in diagnosing temporomandibular joint disorders. I would like to conclude by acknowledging Dr. Vasundhara Bhatt Patil, the Dean of GDC Mumbai, who gave me permission to speak in this conference here, the staff and postgraduate students of Oral Medicine Department. Special thanks to Dr. Mandana for inviting me as a guest for this session and the entire organizing team of Oral Pathology 360. I cannot forget my teacher, Dr. Hemant Umarji, because of whom I am standing in front of you and delivering this talk. Thank you, sir, and thank you all for a very patient hearing.
Yes. That was indeed very, very interesting, I must say, even though I have to make a confession that radiology is not one of my most favorite subjects, as you might imagine, but this was really very interesting. Thank you. Reminding everybody, please put in your questions and comments in the chat. And while you do that, we will just give you two short updates. One is that we have an upcoming master class on biopsy techniques in oral and maxillofacial diagnosis. It is going to be on the 13th of September. It's a 2 hour event, and you will get a certificate of attendance, and you will also have 15 days access to watch the whole recording again. And there is a special discount that is there till the 15th of August. So make the best of it and definitely register. And you can check out the details on our website. On the home page, you will find the link to the specific page, but basically on the home page itself, you'll find it. It is www.oralpathology360.com. I've also given the link in the description. And going forward, reminding everyone again, please save the date for this year's conference, which is decided, and it is 8th to 10th of May. If you want to be able to get early information and special discounts when the registration opens, well, fill up the form. It's a short form so that we know what you are interested in and we will keep you updated. Right. With that, let's now come back to our discussion plate. Yes. And see whether anyone has any questions. Hello, everyone. I can right on top see Dr. Ashwini Deshpande, who's here. And she, but for everyone's information, she has also presented the lecture on TMJ, but ultrasound diagnosis. So, yes, Dr. Easwaran, that was really nice. I must say, when you explained it, it all made sense.
Thank you. Thank you so much.
You're welcome. So, what would you like to tell everyone? I mean, so many years of experience. Uh, what is your suggestion to everybody who may be involved in these techniques, who may actually, I mean, the radiologists for that matter, who actually do this work? So, what is your suggestion to them to get the right image every time?
Yeah, as I told in the presentation itself, the conventional methods have now gone into limbo. Most of us don't practice it. But I think as a radiologist, we should be aware of these techniques. They are definitely a little bit difficult to master, but in a situation where you don't have an access to advanced imaging methods like CT and MRI, in many of the cases, these conventional methods are sufficient for the initial diagnosis. And the TMJ has always been a gray area, even for me in the past. And diagnosing temporomandibular joint disorder is a big challenge. So one must master these techniques. And lately, one thing which I have observed is we have got used to CT and MRI, and slowly we are forgetting the conventional, which is not a right thing. I feel OPG, of course, maybe we are familiar, and that is why I thought I should cover even those techniques in my talk.
Yes, true. Very interesting. Let's see. I think Professor Hiller from South Africa has something. Thank you for presenting such a nice, comprehensive tour of TMJ imaging. Can one request a limited CBCT of the TM joints? Is it possible?
Uh, by limited CBCT, do you mean a small FOV?
Mm,
If if it
I
means
would.
in different FOVs which can be taken. So a limited FOV is a small volume that can be taken. Now what happens is temporomandibular joints, I would recommend to go for a full volume CBCT only, because when we take a lower face or upper face, the entire joint may not be covered in that. For example, I mean, in a fully grown adult patient, the FOBs normally stop at the level of the temporomandibular joint. So if you take a lower face scan, probably the upper portion of the condyle and the entire fossa may not be covered. So I will recommend a full volume instead of a limited volume CBCT for temporomandibular joint disorder.
Good. Okay, that's what he meant is just the joint. Can you do just the joint?
Yeah, we can just focus it over the joint also. But as I said, the joint
Hmm.
deformities or dysfunctions may be associated with other jaw disorders also. For example, condylar hyperplasia, you will have a deviation towards the opposite side. So when you want to see the entire facial skeleton comprehensively, it is better to go for a full volume instead of a limited volume for the temporomandibular joint. And there are modules where you can just scan the TMJ also without the remaining part of the face. You can scan bilateral TMJ. Even that facility is available with the CBCT. So if you want only the joint, you want to check for only arthritic findings, yes, you can take the joint module also.
Very interesting. We have another question from Blurosy. How do you correlate imaging findings with clinical symptoms when they don't match?
Yeah, that is a very challenging task actually. I think we need to, the correlation is very important. For example, I showed you one case where the open and closed mouth TMG view was taken. Suppose a patient is clinically showing inadequate mouth opening, and on the radiography is showing excess mouth opening. It means somewhere clinical examination has gone wrong, or there is some muscular dysfunction because of the patient is trying to guard and not opening the mouth completely. And even the vice versa can also happen. Radiograph may show reduced movement, and clinically you will find more movement. So in that case, I feel we need to go back to the clinical evaluation once again and see where the mismatch has taken place, and then try to again correlate. That might solve most of our problems, because particularly when we see OPG, the patient bites on a small bite block. So in that case, the mouth is not a strictly closed; it is partially open. So we need to take into consideration the technical aspects of the imaging technique, how the patient has been positioned. Is there any mistake in the patient positioning that could have resulted in a mismatch? That also has to be evaluated.
Yes. Thank you. That was, in the last, I mean, overall, I have come across, especially on LinkedIn, there are the whole discussion groups on TMJ, problems and the joint pain and basically all the various classifications I go through. Something very interesting the other day I read was, of course, this was as a part of an implant rehabilitation, full mouth rehabilitation, where they basically managed to, I guess, recreate the vertical dimension which must have been lost before. And in the process, the patient who had lost her or his hearing, the hearing returned.
Yes, there was a newspaper article a couple of weeks back. Yes.
Yeah, okay. So I guess this was a continuation of that. It is very interesting, but that means that the problems with the TMJ can be quite far. I mean, we all know about the headache and the neck ache and all those things, but it can be really very far reaching. So, in which case, how do you even begin to pinpoint the clinical symptoms?
I think the case which you have mentioned is a very rare event that has happened, and we don't know whether it was a coincidence or whether there was a correlation between that.
Yes.
I think the classical symptoms of temporomandibular joint disorders is pain, reduced mouth opening, difficulty in mouth opening, clicking sound, and deviation, deflection. These are the classical symptoms which specifically point towards the temporomandibular joint disorders. Now, certain symptoms which can be confusing is earache, headache, neck pain, which can be with many other conditions like, say, for example, some ear infection, cervical spondylosis. So I think we need to depend upon more specific symptoms of temporomandibular joint like clicking, deviation, deflection, tenderness on palpation, which is definitely indicative of a temporomandibular joint disorder.
That is true. I guess finally, if there are more severe symptoms, basic symptoms will also be there to look for.
Yes, yes. And
That is
sometimes
very
the TMJ can be a site of a distance, not a typical joint condition. For example, the case of osteomyelitis, which I showed. These days, we are seeing many cases of tuberculous osteomyelitis involving the ramus and temporal mandibular joint. So there also you need to be aware that it is not a intrinsic joint disorder, but infection which is unfortunately affected the temporomandibular joint. So that can also present with pain near the angle of mandible, swelling, redness, pus discharge. So all these symptoms could lead to a diagnosis of some temporomandibular joint disease.
That's true. That tuberculosis case was very, very interesting. Yes. So we have, I think, one more last questions, which hasn't. Okay, it has come here. So Rumi is asking, can open and closed mouth lateral transcranial radiographs definitively diagnose disc displacement?
Yes, that is a very interesting question. So, as I told you, these conventional radiographs do not directly show the disc, but we can correlate. For example, in the patient's mouth opening is reduced in the open mouth position, and clinically, when you have a hard and feel, when you try to open the mouth, that would lead to a diagnosis of internal derangement without reduction. Suppose in open mouth, the mouth opening is normal and clinically patient has got a clicking sound. That would indicate that there is a IDD with reduction. So though transcranial views or even the TMG open and closed mouth directly do not show us the disc, we can definitely use them as a guiding along with the clinical findings. We can use these techniques for diagnosing internal disc displacement. They are quite reliable also, I feel. And of course,
That's
ultimately, MRI is the gold standards for the disc.
that's true. But it's very good to know the basics also. I mean, conventional methods and MRI is not always accessible. So this is a good thing to know. Okay, we have from Eminis. Are there any specific guidelines to consider in diagnosing TMJ disorders with CBCT? I can't
Not
figure out what is the last part. Okay.
Yeah, there are as such there are no specific guidelines as it is, but these guidelines are the principles head, joint space, the subchondral sclerosis, osteophyte formation. As such, there are no specific guidelines, and except for maybe internal disc derangements and joint effusions, rest all pathologies can be seen beautifully on a CBCT. Rather, CBCT is better than CT scan because the bone window of CT scan is going to show it almost similar. With the CBCT at a lesser radiation exposure and a much better clarity and resolution, we can see the very small structure also very clearly. So, no specific guidelines which I have come across. In case anybody has, they can please share with me. I will be happy to read that once.
Yes, that would be interesting. And we just have, we will take these last two questions. And okay, what is intervention radiology in TMDs?
Interventional radiology, as such, I don't think there is much scope of interventional radiology in TMDs. Maybe you can use it for CT guided arthrocentesis. We can try doing it when we want to precisely locate the joint spaces. But unlike the other joints, I have not come across much, or I don't have much experience about interventional radiology in TMDs as such.
Right. So we have the last one, which is a comment from Dr. Ashwini Deshpande, who says, "Brilliant presentation, crisp and clear, and lectures are always perfect." Well, I
Thank you.
have to
Thank you.
agree.
Thank you.
I have heard two of your talks, one in the conference and one now, and I have to agree. Yes, very, very, very crisp and clear. Okay,
Thank you.
so do you have any last comment before we go on to your certificate?
No, I want to thank you for giving me opportunity, inviting me. It was a pleasure. Even last time the conference as well as today, I got to meet many delegates, not only from India, from outside also. So I want to thank you for giving me an opportunity. That's it. And
The
thanks
pleasure
to all
was
the
all
listeners
mine.
also.
Yes. Yes, thanks to all the listeners too. So with this, let me yes. This was truly a very insightful, in-depth, and very clear, lecture. Didn't feel like a lecture so much as it felt like a conversation. It was really very interesting. So, on behalf of Oral Pathology 360, I'm truly pleased to present you with this small token of our appreciation. Thank you so much.
Thank you so much.
And just before we wrap up, let me share with everybody about what is coming up. So, we are going to have this Saturday itself. Do not forget, we are going to have. First, let me see if we are hearing this. Yeah, we are going to have a journal club with authors. This time, the author who will be joining us is Professor Baloch Zubair, who is an expert in salivary glands, and this is a great work that they have done. The largest collection of hyalinizing clear cell carcinomas is what they have examined, and you will be able to talk to and ask him questions yourself. So please attend. It is at 7:30 IST on this Saturday. Don't forget. And yes. Another thing, of course, to our audience, at the beginning of this session, in the chat, I have shared the playlist of our oral radiology lectures. You will find a lot of interesting things there. So you can follow that. It is also there in the discussion. And yep, it has been wonderful having you with us. Thank you so much, everybody. Thank you again, Dr. Ishwaran. Everyone, have a great time. And before you go away, if you like this, please hit the like. And of course, if you can, subscribe and share. All that really helps getting our content in front of more people. That's about it. Thank you all so much again, and see you on Saturday.
Thank you.